Good afternoon and welcome to today's program titled, Is This the End of Population Health? What AI Can Do to Address Socioeconomic Determinants of Health. My name is Erica Randall and I'm the Content Manager for HealthLeaders and will be your moderator for today's event. Our program will be 60 minutes in length. Note that on your on-demand version of this program, it will be available approximately 1 day after the completion of the event and can be accessed using the same login link that you used for the live program. Today's program is sponsored by Jvion. Thank you for being our sponsor today, and to you, our audience, for giving us your time and attention. Before we start, we have a few things that I should go over. First, to ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Second, you will find a resource list for today's webinar in the lower left portion of your screen. Here we have listed the webinar slide deck for you to interact with. Third, at the bottom of your console are multiple widgets that you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical questions. At this time, it is my pleasure to introduce our speaker for today's webinar, Dr. John Showalter, who is the Chief Product Officer at Jvion. Thank you, John, for taking the time to speak with us today. And with that, the audience is yours.
Thank you, guys. I appreciate your time this afternoon. I'm really excited to discuss AI and socioeconomic determinants of health. Quick review of the learning objectives. We're going to work on defining AI and what that means for community risk-based predictions. Look at the shortcomings of current analytic techniques. Describe the data that's required to use AI for socioeconomic determinants of care, and identify potential areas for application and improvement with the technology. So, jumping in, why AI matters and why AI today. So, AI has been around for decades. Artificial intelligence was first coined back in the 50s, and it was originally used to refer to calculators. The first computerized adding machines were referred to as artificial intelligence. That's evolved throughout the last 5 decades to include advanced rules-based engines, natural language processing, automatic adjustment to photography, interpretations of images, and now in healthcare, interpretations of x-rays, CAT scans, and data from the electronic health record and outside. So it's an evolving term, but really we've reached the point where today's AI, which is really a cognitive science type approach and a visual or language interpretation approach, is possible today because of the compute that's available in the cloud space, the ubiquitous access to processing speed that's been brought about from Microsoft and Amazon, as well as how much it's been ingrained into everyday life. So the ubiquitousness of smartphones, people are out there with Fitbits and end-user devices, and artificial intelligence and advanced algorithms are monitoring what we buy and what we watch and making suggestions on Netflix and Hulu for what other shows you're going to enjoy or what other people have bought on Amazon. And we are very used and acclimated to mathematics helping us make decisions and form our decisions. And healthcare is a bit of a laggard, actually, on that. So healthcare is new to this, but is expected to become very engaged over the next, 5 to 6 years. But currently, about 50% of all AI in healthcare is a clinical application, either diagnostic in radiology or augmenting decision-making for clinicians, operational applications, things in supply chain, or helping with billing, coding, or accounting on the financial side. But it is estimated that we're going to have compounding growth of up to 50%, which would make the overall spend in AI and healthcare $36 billion by 2025. And that is a very rapid adoption, but very similar to the adoption that we've seen in other industries, or similar to the adoption of smartphones. So what does it mean, and why would we use it in healthcare, and where are we really going? So I'm one of the people that gets annoyed when they say they're going to replace me with AI. Actually, one of the memes that's going around that I like the most is that, AI isn't going to replace doctors, but doctors that don't adopt AI are going to be replaced. I think there's a lot of that augmentation that's true. But to understand the augmentation, we need to understand general AI, which is computational methods that are intended to make the computer seem or actually be as intelligent or choose intelligent behaviors as a person, whether that's decision-making, emotional, or social behaviors. And really that's still kind of in the development/pipe dream, even remaining ethical questions about whether that's a good idea. When we're talking about AI, we're really talking about narrow AI. So it's a computational method that's to address a specific problem or a specific area, whether this is playing chess or Go, whether it's translating English to Spanish in real time, self-driving cars, image recognition, or helping clinicians identify potential problems in a patient. And those methods are really designed to augment the end user, to make you better at making decisions or doing what you're doing. And the AMA was really one of the first ones to use it, but really focused on augmented intelligence or augmented clinical intelligence. So we're going to be talking today about AI that augments intelligence, not tries to mimic or replace it. So how does this play into social economic terms of care, and where are we looking to have computational and mathematical techniques that augment the delivery of care or the improvement of quality of care based upon social economic determinants? The first thing to realize is how important the social economic determinants really are. The estimates are out there that between 60 and up to 80% in some studies of your clinical outcomes are driven by the social economic situation that you live in. And social economic determinants of care are really the conditions that you live in and where you work, where you play, what your social situation is, what your peer group is, and then they interact with chronic conditions, hospital utilization, how sick you get, what are the sequelae from an illness, and ultimately even relate very strongly to mortality. There's a very strong link between having challenges with the social economic determinants and oncology treatment. Those that have barriers and challenges have a higher mortality rate, have a higher rate of disability after treatment. And this is, I think at this point, after decades of study, just a accepted foundational truth that, where you live and what your access is directly plays into what's going on socioeconomically. So it's estimated that the annual healthcare expenditures are above $3 trillion, directly related and correlated with the increase in chronic disease and disease burden. So it's a very expensive problem. It's a very difficult problem to tease out, and one of those complicating factors is how do you approach the social economic determinants risk in a effective and even efficient way. So the most streamlined way is to analyze a community and then have the populations within that community inherit the traits of the community, and then the individual inherit the traits of that population. So what that ends up looking like is that you are going out and you're doing a door-to-door survey of a statistically representative sample of the community, and you roll up and say, this neighborhood, this geographic region, this block, this census tract has these problems. There are financial challenges, there are air quality challenges, there's transportation challenges, and then you pull that down and do population analysis and say, what does this look like for pediatric asthma? What does this look like for the elderly population? What does this look like for populations with diabetes? And then you take that population and say, all asthmatics in this population are identical, and you try to come up with plans to help address them. Where that really falls apart, and there's a really good study out of Intermountain Healthcare that looked at a adverse determinants index and showed that pediatric patients with a high adverse determinant index had longer lengths of stay for their asthma, had more visits for their asthma, and had worse outcomes for their asthma control. But then they also did an analysis of that population and showed that was entirely true unless you had private insurance, and if you had private insurance, then your outcomes were equivalent to people without living in areas not in that adverse determinant index. So essentially, all of the social economic determinants in that population were wiped out by having private insurance. And what that also translated to is that the average of patients with and without insurance was bad enough to pull down the entire area, but those without insurance were even much worse off than the analysis showed. So taking it from the population and inheriting actually made that population look healthier than it truly was. The other approach is to go from the individual up to the community. Today that looks like using a 15-question screen, a 20-question screen, or up to a 75-question comprehensive screen, and you try to capture everybody coming through your door, and you then roll that up to the population, and then roll those populations up to the community. The difficulty with that is that you are then relying solely on what the individuals are reporting. So if they are not reporting transportation challenges, or they're not reporting social support challenges, or if you take a yes-no box, so are you married, yes, no, patients who have a spouse with dementia living in a nursing home will still check the yes box, I'm married, but do not have the social support. Because we kind of very frequently, especially on these individual questionnaires, say people that are married are more likely to have social support. That's a positive social support sign, and we roll it up to the community and say, wow, this community has really good social support, even though perhaps it is an elderly community where there are a number of patients that are still married and either dealing with a spouse with chronic disease or a spouse that's in a nursing home and don't actually have that social support. So with both of these methods, you end up frequently with misaligned data and the inability to really have the impact that you want. They have their pros and cons, and on the community to individual, it's really easy to access the data. You can go to the census track, and the U.S. Census has been really good about making an API, and you can pull down the knowledge about what's going on in that group of neighborhoods. You can go to the USDA and get pollution counts. It's very quick to do the analysis, and you can prioritize at a macro level what investments you need. But again, you can't identify the individual specific problems that are going on. You can't tackle an individual person. You are dealing with the entire community. The gaps in understanding, again, lead you to possibly working with a patient population that has private insurance and asthma outcomes are fine, when you really need to be focusing on those in that community that do not have private insurance because their outcomes are really bad. And when you build from the individual to the community, you get a deeper understanding of the individual socioeconomic determinants. But again, they're self-reported, and you're dealing with the bias that's in there. You do pick up the ability to deal with and engage that individual and get them the appropriate resources. It's very time-consuming to do this. If you look at the number of minutes it would take for you to collect even 25 socioeconomic determinants on 300,000 patients to get your entire population, that's a very big lift. And the workflow considerations and the considerations around whether or not your clients are really excited about sharing this information and why you're asking it are all barriers to going from the individual up to the community. So why would we apply artificial intelligence to this? Because these problems because of the solutions we have aren't working. We are not successfully implementing the top-down identification of food deserts to deal with food insecurity, the identification of transportation or access issues to get people to appointments, and we're also not successfully understanding at an individual level what challenges are truly contributing to a patient's health risk and who's managing them and who's not managing them. And it provides us a challenge and a opportunity to figure out how can this be different? What do we really need to be able to do? And we need to mash up the two current approaches. And we need to understand clinical healthcare risk in the absence of clinical data. So how do we understand what's going on at the individual level while not having to collect any data from the individual and having access from the census tract and from the USDA? And this is really about bringing in all of the data assets that are currently out there for individuals, and doing so in a ethical and privacy conscious way. So right now, most of you to all of you have your phone somewhere nearby, and on that phone you have apps, and in those apps you sign a contract that you are allowing someone to track some amount of data about your access, whether that's Amazon or a game you're playing or the geolocation. You probably mostly get a little alert that says, can I know your location inside or outside of this app? Depending on which button you push, either they know where you're at when you're using the app or they know where you're at all times. That data gets sold to third-party vendors and is right now most frequently being used to drive marketing and advertising and can be extremely granular. You can go into Google Ads or Facebook and actually select, I want to advertise to people that search for this specific term, and ads and things will pop up for you. So that data is out there and available for purchase. We strongly believe that data is beyond the reach of what we should be looking for healthcare. But it does generate good metadata about the individual. So, you can put somebody on a scale from 1 to 10 on how likely they are to buy from Amazon, a scale from 1 to 10 on how likely they are to buy through the mail. Another strong source of data is actually your membership card at your grocery store. It collects a lot of data about how you buy, and now that a lot of that is also possibly online for shipped to your home, they're gathering information on what your propensity is to purchase from your phone, over the internet, or actually come into the store and shop. And those all create valuable indexes around purchasing behavior, access to technology, understanding, and a bit of digital fluency. And you're able to take all of this information that is out there and feed it to a machine that can handle thousands to tens of thousands of interactions of data, and begin to do something that augments the decision-making and the intelligence of the solution. So what would that look like? Assuming that you can take all of this data and understand what it means for a patient's risk for their health outcomes. So you would be able to build individual profiles on what their social economic determinants of risk look like. So, John Showalter living in Jackson, Mississippi has, this as his first social economic problem, this is his second, this is his third. Jane Smith living in the inner city Atlanta has food insecurity, income and transportation as her biggest factors in that order. Bob living in Virginia in a steel town or a coal town, their number one problem is air quality, followed by digital fluency. So you can begin to build individual profiles and understand what actions to take at the individual level. Once you understand what's going on with those individual levels and you know where they live, you can build that into the population, and you can begin to understand what social economic determinants for that population are really driving the use of the ER, the use of the hospital, and then, again, taking whether that's the pediatric asthmatic population, the elderly population, or a neighborhood or block population, and build that out to a community. And you can then put the communities on top of the communities and understand what's going on in a state or what's driving differences within a state or a zip code or a municipality, and really begin to hone in and make sure that you are putting the right community resources where the right needs are. Think about the difference between a community that is being driven by food insecurity, where there are already organizations, and there's a soup kitchen and a food bank, versus another community that is in the same situation, that's top risk, and the only food source is the quote groceries that are available at the local tobacco store, because it's the only thing that's accessible, the only thing that's taking food stamps or food assistance medication. And I can absolutely point you to communities in Jackson where the only place that's within walking distance for somebody living in a food desert or food insecurity area is the local gas station that actually takes the state access card. So if you have diabetes and your food access is really the Twinkies and the hot dogs at the gas station, it's going to be very difficult to control your diabetes. So understanding that that's what's going on in that community, as well as understanding which individuals in that community are in most of need of help, allows you to begin to address both the social economic of the individual and the community, and bring those two charts together where community down and individual up really were both lacking, and bring them together and see across all of them. In order for this to be meaningful, it means that you actually have to be able to do this. The good news is that artificial intelligence can do this. It is possible to take all of the publicly available and purchasable data, put it through a intent-driven machine, and accurately predict which patients are going to utilize the healthcare system, even without knowing anything about their clinical aspect. So when we look at the risk of an inpatient or emergency room visit within the next 90 days, we are able to identify almost 80% of everyone that was admitted, so our sensitivity is about 80%, and the specificity is about 0.7, which makes us a very accurate prediction and understanding of risk, because if you take the top third of risk, 80% of all of the utilization is in that top third, and the remaining 20% is in the bottom third. The bottom 2/3. And whether you're looking at the combination of inpatient and ER, or just ER, or potentially even more importantly, just those inpatient admissions that are potentially avoidable, those that are from COPD, CHF, diabetes, the potentially avoidable as defined by AHRQ, you are able to accurately understand who is going to utilize just off the social economics. And that allows you to then dig down and figure out which of those are most important for decision making. So what we learned from doing this analysis was that air quality actually was the most important determinant of risk. It's important to note here that these are associations, not causation, and being important for the determination of risk does not necessarily translate to the most causative agent of that risk, but it does mean that there is a very different outcome for similar patients that live in areas with good air quality and poor air quality. So it is a big driver of utilization in very similar populations, and that it frequently comes up in the machine. The second one, not surprisingly, was income. And then the third is neighborhood in-migration, which is really looking at what percent of that neighborhood is new. So it's a reflection of neighborhood turnover. It's a reflection of social support. It's a reflection of possibly expansion of that. So it can either be in an area that's in a boom where the population is now outstripping the resources because it's rapidly expanding, or it's a population facing a lot of turnover and can signal housing instability. All three of those are actually more important than the race or ethnicity of the individual or their gender. Air quality and income were actually more important than the age of the patient in deciding their utilization. Transportation and purchasing preferences were also more important in the decision making to the AI machine than the race or ethnicity. And this really comes down to access to vehicles, access to public transportation, and very interesting was the purchasing channel. So it's a reflection of, do you shop in person? Do you shop over the phone? Do you shop over the internet? And it's an indication of digital fluency and access to resources outside of your community. So those that are very adept at internet shopping seem to be more likely to overcome their social economic challenges than those that are not, that have a less of a preference for it. and that's followed then by population density, social support, education, financial security, housing stability, and food access. So understanding these as the major drivers of social economic determinants of care has been here. So this was a supervised AI in the sense that we knew the outcome. We knew that people had a hospital visit. We worked with health systems to understand which patients actually utilize their health system. We did this study across 3 different geographic areas. And the interesting point here is the things that we did pick up that we haven't really seen much in the literature, the importance of digital fluency, the importance of retail access. So not only access to food, but access to other stores, as particularly pharmacies. And then, the employment sector, what actually are the predominant jobs that are in that community, were also a driver in this decision making. The ability to understand and rank these at the individual patient becomes very powerful then. So through the analysis and technique, we are then able to determine for each individual what is actually driving their risk. This isn't black box, so we know that for this patient, health literacy, social support, and food access are their drivers for risk versus someone else where it is income and transportation, and those are very different individual actions that we can take. So what does this mean for population health? So the ability to augment our decision-making, augment our intelligence with this data, knowing that we can understand true health risk even without clinical data, lets us understand the individuals. What effect is the community having on the individual? Clinicians can be more prescriptive with the actions that they are taking on the individual level. I know that these are the 3 things that I need to investigate and tackle. Again, this is there's population data, there's purchase data, there's behavioral data. So this all still needs to be at the individual level, fed back through a clinician, have a clinician potentially do some screening, ask some questions, but the ability to hone in on, of all the possible things that could be negatively impacting this patient due to adverse determinants, these are the ones to focus on and can get streamlined work going, we think is very important. The validation of the risk prediction, the ability to know that this isn't a risk scale, but this is an individual assessment of this patient's likelihood to utilize the health system because of the AI and the augmentation, not just a point scoring that says, oh, you live in a food desert and you live in an area of low income and you have poor air quality, so you have 3 points, that's bad. For one person, that may be bad. For another person, they may have private insurance and overcome all that. So understanding at a much more granular individual level allows us to build plans and identify the right intervention across the continuum of risk. So the technique puts all of the individuals and within the communities, within the populations on a spectrum. So you end up with everyone that is analyzed is put on a 0 to 1 scale, and you're able to understand the complete continuum of risk across the population, which allows you to aggregate that to understand the continuum of risk within the populations and the continuum of risk across communities, and really build where to start, what has to happen first, what has to happen second, and where you really need to go. Oops. And most importantly, at least in my opinion, what does this mean for patients? So much higher engagement, much more direct engagement. Providers can identify proactively the right resources. Should we, in the team-based care model, should we already get a social worker involved in this? Should we get a case manager? Should we have food access resources lined up? Should we already have looked into our system and identified where high-quality food would be? Are there ways to educate you on using Walmart's app or Amazon to deliver higher quality food to you, since you actually can't go access it? Can we get you air filters on a scheduled on a schedule so that you have air filters every month, so they come to your house, so you go ahead and change them if you have COPD? What are the things that we actually can drive at the individual level? Community resources can be better targeted and better aligned. So we've had several conversations with health systems that are really dedicated to their community benefit, and they've gone out and they've listened to their communities about problems in their communities, and they're helping with those issues, but it's not clear whether those issues are directly tied to the issues that are driving healthcare utilization or poor health outcomes in those communities. There are definitely problems that are there, but are you solving the right problem to address the outcome that you're trying to address? Is it more important to have a food bank? Is it more important to have an air quality program? Is it more important to get a bus stop? Those are all very real questions that need to be answered if you're dedicated to improving community benefit, and this information augments those decisions. Better resource allocations, better ability to strategically align the community needs and get a healthcare return on investment when that's what you're going to do. Is housing security, is high rent actually the issue in that community, or are there ways to deal with the issues that are stemming from the housing insecurity? Multiple health systems and payers have announced multi-million-dollar plans to work on housing security, which are clearly absolutely fantastic community benefits, but it's not necessarily so that the communities that they're helping, that's going to reduce utilization or solve the problem. So having better housing stability in an area where the risk is being driven by poor air quality does not necessarily mean that your asthma and COPD patients are going to utilize the system any less. And ultimately, and most importantly, the ability to improve outcomes, drive higher engagement, tailor the interventions, and tackle both the community down and the individual up issues with addressing social economic determinants of care. So what we see this looking like in practice does come from both of those directions. So an ability for a patient to come into clinic and have that clinic prepared to deal with their top 3 to 5 social economic determinants that are seen to be driving those risks, have those resources at the ready for them, with the, assuming that after you've done some in-person questions or screening, they do screen positive, that you do identify those problems. How are you going to help them with their digital fluency? How are you going to help them with the poor air quality? How are you going to help them with their transportation? Do you have programs in place to address them? And it really comes into a scarce resource management, because you can't provide shuttle service and transportation or Uber grants or taxi tickets for everybody with the transportation issue. But if this patient is high risk for utilization and that's their driver, maybe that's the patient that gets that. And then you start at the community side where, we've looked at maps where there's transportation access and there is public transportation and a bus a mile or 2 away. How do you end up connecting this community with poor transportation to the bus stop? How do you adjust the bus lines so that somebody could actually get from their house to the hospital or get from their house to the multi-specialty clinic? Is the multi-specialty clinic on the bus line? All of those decisions around transportation that you can actually look at visually requires, some amount of geospatial analytics, and definitely a next phase of this is to take this underlying analysis and get it into a geospatial representation so that you can do community analysis. You can look at, these are the problems in the community, and these are the resources that are available to that community, and these are the gaps that we need to fill. So we're very excited that artificial intelligence has reached the point that it can absolutely augment decision-making both at the individual level and the community level for social economic determinants of care, and that this can be done with techniques that don't involve collecting any data directly from the patient. Clearly, there will need to be follow-up at any individual level collecting data, but collecting data on 3 to 5 points is much different than collecting it on 25 points, and when you can target those most at risk, you can do things much more efficiently in your clinic. As a PCP, very used to the concept that risk is first identified through some sort of screen, and then we target and deal with and adjust that risk. So with that, I will open the floor to questions.
Thank you so much, John, for an excellent and really interesting presentation. So now this brings us to the Q&A portion of the program, and we would like to invite you to ask live questions of our speaker. So as you're writing in, and it looks like we have a lot of questions to answer, how you submit a question is click on the Q&A widget at the bottom of your screen. It may be open already, and it would appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewable by other audience members. All right, so let's get to our questions here. And the first question, John, is, does this approach tend to have the greatest benefit in urban settings, suburbs, or rural? Larger tract states like Alaska, or smaller or dense states like New Jersey?
Sure. So let me jump back to this slide.
Sure.
Yeah. So we did look across urban areas and rural areas. We did not go to Alaska or Montana or South Dakota. So the very large, very rural census tracts are potentially outside of this analysis. Where we do clearly see the greatest gaps when we're doing this are, well, it depends by determinant. So air quality, food access, transportation actually are very urban determinants that come out. Air quality, when we get out to rural Virginia, the air quality there is generally considered much higher than what we're seeing in the urban setting. So the factors that matter to those communities shift, but this level of accuracy and understanding of the population we have seen effective across rural and urban Virginia, rural and urban Ohio, urban Georgia. So we've seen it be effective across multiple geographies, but would call out that we have not, in a very sparsely populated area like Alaska, or at least regions of Alaska, we have not had it tested at that in those populations.
Okay, thank you, John. Our next question takes us back to slide 16, so if you want to look at that. And the question is, what is the source of the data presented on slide 16, what we learned? Is this U.S., national, state-specific, or some other population?
Sure. So there are hundreds of data points that are coming from multiple areas to do this analysis. So we are pulling information from the U.S. Census. We're pulling information from the USDA. We're pulling information from the Weather Service and a few other nationally published government-collected data sources. We're also purchasing information from the third-party data brokers on individuals and indexes on those individuals. So what is, what are markers of their digital fluency? What are markers of their channel preferences? Very much the same data that you would be purchasing as a marketing company if you were targeting ads or trying to sell shoes or soda. But that information is purchased on an individual level that allows us to have much better insight into social support, income, employment. So the two big sources are third-party data that is purchased and then nationally published government resources. And generally, a follow-up question to that is how old is that data? The government data tends to run, 1 to 5 years old. The purchase data tends to be on the order of months.
Great, thank you, John. Let's stay on slide 16 for a minute. Somebody has asked, they noticed that health literacy was listed. How important or to what degree did this play in the need?
Yeah, so in our analysis, health literacy was the seventh most important factor in determining the patient's risk. So it is a top factor, and health literacy is one of those purchasable areas. So we're able to purchase data on people's beliefs about medications, people's knowledge about internet resources, people's understanding of their health problems, and it plays a significant role, especially on the positive side. So those that have high health literacy are able to overcome lots of barriers. Those that have low health literacy but are in advantaged areas tend to suffer much less than those that have low health literacy and are in adverse or challenged areas.
Great. So, John, our next question is asking you about what do you wish you had known when you started this work?
Oh, that's a good question. So when we're, the granularity that we would like to have on all of these variables is probably where we would have liked to know more, because the artificial intelligence techniques only work at the granularity that you provide. So given how high air quality came out on this, we would have dug in and done more granular air quality measurements. Well, not done the measurements. We would have found more granular air quality data sources. There are additional data sources around pollen counts and other air quality metrics that we could pull in. So I would have said I wish I knew that air quality was going to be as important as it was, because we would have done greater granularity on digging on that. Also, the neighborhood stability information, the neighborhood in-migration definitely was an unexpected kind of finding. It makes sense as we dug back through, relating to, again, either the booming neighborhoods or those that are turning over rapidly, representing instability. The risk of healthcare utilization within the first year after moving is actually well documented. We didn't really go looking into that until we found this factor. So, I'd say, I guess I wish I knew the things that were going to come out on top, because we went with a shorter list that we thought was going to end up coming out of the analysis in the machine. But, as we look at doing iterations of this, that's, those are the lessons learned, and those are the things that we're trying to track down and get better data sources for.
Great. Our next question is this. Do you see our government and other local municipalities adopting these models to use in determining the available health choices for a community?
Well, I hope, on the positive side, I hope so. Information and augmented stuff can always be a double-edged sword. So to augment the resources, I certainly hope so. I think North Carolina is a good example. They've gone through with their Medicaid waiver and have $600 million to spend on socioeconomic determinants or community benefit activities through the Medicaid, the federal Medicaid funding. So yes, I do hope that they use data-driven techniques to augment their decisions about, where they do put food banks, where they do, supplement bus routes, where they do, tackle air quality on a bigger scale. I do think there are some progressive state health and human services and public health departments that are tackling this, but I think there are more that are not.
Okay. So our next question is this. Given limited resources, does it make sense, based on what you described, for healthcare provider organizations to target community-based organization efforts at assuring that the populations they serve have healthcare insurance to most positively inflect the social economic determinants of health, impacting their community's health and quality of life? And I know that's detailed, so I can repeat it if you'd like.
You may just have to let me know what I missed, because even repeating it, I might not remember it all.
Okay.
But I do think it's very important, and this is where, getting to this next level where you get to incorporate this with geospatial analysis, which is essentially mapping, right? So that you can map and see this community already has a food bank. If they already have a food bank and it's a food insecurity problem, it's definitely an area where, as a health system, providing rocket fuel to that food bank. If they're currently only able to meet 10% of the need, and you can get them to meet 70% of the need through whatever method, whether that's cash infusion or food donation or partnerships, clearly going to help that community, clearly going to help that medical center's use of underinsured and uninsured utilization. So there's definitely a synergistic effect there. I am a believer that health systems should stay in the business of healthcare delivery, which means working with community partners. So if there is, not a social support program, or if there's not, transportation, what are the community resources that they can work with? From my perspective, I would be, a bigger fan of subsidizing the two extra bus stops. That would be helpful, rather than necessarily starting a shuttle service as a healthcare system. But clearly, that can be debated 6 ways to Sunday and is only one man's opinion. But however it's tackled, we have, we have clients that are tackling this by help me identify the patients that are most challenged and look like they're going to qualify for some sort of subsidized insurance or Medicaid. Let's get them, either signed up through a health insurance exchange or for Medicaid, and let's get them insurance, because clearly they're going to need it, and that's going to help reduce their burden. We have other clients that are starting food as medicine programs, working with local food banks to make sure that the patients that they're most concerned about are getting assistance from the food banks if they qualify. So the idea that you can strategically and targetedly work with the community resources that already exist as a health system has a lot of appeal for me when I'm thinking about the best ways to tackle social economic determinants of care as a healthcare provider.
All right, excellent. I think you covered it all. Our next question is, what is the incentive for the primary care provider to solve the social economic determinants of health of her patients in the fee-for-service setting?
So there's a couple ways. So I think first and foremost, as a primary care doc, I did primary care for a while. Just improving the health of my patients. If I can, tactically get this into my workflow and get people plugged into the right resources, it may not be that much extra time, and it's certainly worth the time that I have to put in. From a purely financial sense, there are billions and billions of dollars being spent on charity care for the uninsured or the underinsured. And if you can spend $100 getting somebody food as opposed to spending $6,000 of unreimbursed care, clearly that's a financial return. And we do have multiple clients that are looking at these types of analysis to keep the underinsured and uninsured healthy because of the cost that they incur by treating them and not receiving reimbursement. In a PCP clinic where you are truly fee-for-service and you're not part of an ACO and you're not necessarily facing the financial challenges caused by bad debt or unreimbursed care, we are able to just focus on the delivery of improved care. So the incentive, there isn't necessarily a financial incentive if you're in a strictly fee-for-service model and you're not facing bad debt issues. But frankly, if you're in that situation, you're probably in a high social economic area that's not facing a lot of these challenges. If your patient base has, high risk for social economic determinants of care, you are facing bad debt write-offs, underinsured problems, inability to make co-pays, type issues. So, if you can, figure out what your right level of assistance is, there probably is a financial return for most clinics that are facing this problem.
All right, great. So, John, we have time for one more question, and the question is, how is the air quality metric defined?
So the air quality metric is actually looking at the amount of particulates or ozone in the air. It is a extrapolation of direct measurements. So it is looking at direct measurements that are not actually captured on an everyday basis in every census tract. So there is some modeling and extrapolation from it, but it is actually a direct measurement of ozone and particulate matter.
All right, thanks for clarifying that. So that is all the time we have for questions today, and I want to thank once again Dr. John Showalter for an excellent presentation. I also want to thank our sponsor, Jvion, for making today's program possible. And finally, thank you to all the people in our audience for participating today. We hope you'll join us in the future for another Health Leaders webinar. This concludes today's presentation. Have a wonderful day, everyone. Thank you so much.